initiative that you have started with Murai, and it has done a lot of good things, beneficial things to the students, to the teachers also, that the consultants, all the optometrists in achieving some kind of knowledge about this optometric field. So can you please let me know whether the students are hearing me? Am I audible to everyone?
Yes, sir, but you are not that much louder. So if you are using the
Okay,
headset, yeah, now it's good.
no, it's fine, right?
Yes, sir.
So
So yes, sir. So if any student have any question, or kindly you can chat on the comment on the chat section. So you can see on the chat box on the below as well, sir.
okay,
Uh,
thank you so much, Kapil. Yeah. So this is the first time I'm using this Zoom application. So there may be some kind of problems. Anyway, okay. Good morning, everyone. So my name is Krishna Banjade. Basically, I'm from Dang district of Nepal. So a very very good morning to everyone. So without any delay, we'll start our topic today because I was supposed to start my topic at 6:30 and already it's 6:43. Yeah. So I have chosen a topic that is very very easy to study in the college life, and when some of the MCQs come from accommodation, convergence, near vision, complex, these things are really, really, really very tough, and we have to use a lot of brain over here. Okay, so because the main thing that I wanna tell you here is the actual pathophysiology of accommodation. There are a lot of things that are written in the book about the pathophysiology of accommodation, but till now none of the physiology explanations are have given the 100% description about the pathophysiology of accommodation. So whatever we have been studying about accommodation, convergence, and some of the points that I've been adding here in my PPT. So hope this will be beneficial to you in the coming days. I have prepared my PPT in the form of MCQs. The MCQs will go thoroughly from one topic to another topic. There won't be so much of explanations because this is a kind of master's preparation classes. So you'll be asked some MCQs in the preparations. You won't be asked any kind of explanatory questions. Hope in the next in the examination. Okay. So we'll start our topic with a very easy kind of questions. Fine, you will be given some time to think on the questions, and according to the questions, the syllabus will go on thoroughly. Fine. So I request every one of you to hold a copy pen. So you write the answer of the question and find out whether it's true or not. Okay. So since this is not the question related to the accommodation and convergence, then also I have put some of the questions in the initial slides. The most important factor determining the convergence of the light rays on the retina. So you'll be having you have some of the options here. So okay, the refractive power of the lens also has some of the convergence. The curvature of the cornea also has the physical state of the vitreous also has the length of the eyeball also determines the convergence of the light rays. But since the refractive index of the cornea, the curvature of the cornea is the highest, so the answer is C. Okay, spasm of accommodation. We'll go to the spasm of accommodation in the later coming days. Okay, we have a huge topic on this different kind of convergence and divergence, anomalies, their management, and all. Spasm of accommodation. Spasm of accommodation. In this kind of accommodation, we will be the patient will contract the ciliary muscles, So if you contract the ciliary muscle, if you use a lot of ciliary muscles, then obviously there will be a lot of accommodation, right? So if there is a lot of accommodation, it will create some kind of minus power, right? Because the rays of light will converge. So myopia will be the answer for this. These are the basic things, okay? Initial slides, I will explain this kind of thing, and then we'll move towards our topic, accommodation and convergence. So during accommodation, what happens? People dilate, eyes converge. People dilate, eyes diverge. People constrict, eyes converge. People constrict, and diverge. So here, what we have to understand is what are the triads of accommodation in some most of the exams. In most of the exams, the main question that is asked is what are the triads of accommodation, what are the triads of convergence, what are the triads of meiosis. Every time they'll be asking these three questions. All the questions are same. Okay, pupillary constriction, accommodation, and convergence. These are the three triads. Okay, whenever you are trying to accommodate, you have to converge. Whenever you are trying to converge, you have to accommodate, and the pupil will constrict. So the answer is constrict and the eyes converge. So moving towards the supply innovation. So which cranial nerve supplies ciliary muscle? This is the anatomical question. Okay, in Masters of Optometry, the anatomical questions will be very less, I guess, because most of the questions will be asked from the physiology, pathophysiology, and numericals. So, which cranial nerve supplies ciliary motion? Obviously, you know this third cranial nerve, right? Okay, sympathomimetic drops. So you have to understand about the drops also, right? So basically, when you are doing a clinical work, you are using dilating drops, right? Phenylephrine, tropicamide phenylephrine, amytropine, atropine, cyclopentolate. These four drops you will be using for dilating the drop. Sympathomimetic drop. First of all, you have to understand which nervous system is excited by sympathomimetic drops. Parasympathetic nervous system or sympathetic nervous system. Sympathomimetic. It means it's exciting sympathetic nervous system. Sympathetic nervous system dilates the pupil. Parasympathetic nervous system constrict the pupil. So here is the thing, right? Parasympathomimetic drugs they help parasympathetic nervous system. Sympathomimetic drugs they help sympathetic nervous system. Sympathetic nervous system dilates the pupil. So the answer will be B. So what happens during convergence? This is another question. What happens during convergence? Right. So the eyes, whenever they are looking at a far object, the eyes are straight. They are supposed to be straight. So whenever the eyes are looking at any object that is closer from the far point of vision, if the eyes are coming nearer, the eyes make a certain angle. They are trying to make a certain angle so that the angle slowly increases if you come closer. So the angle found by the visual axis increases. So this is not a kind of question that will be asked in your exam. What happens during convergence? I am writing this MCQ with only three options just to make you understand what happens during the convergence with the visual angle. The visual angle increase. Okay, you have to keep in mind. Some other MCQs will be asked by this from this question related to these questions regarding the angles also. Okay, so you have to understand what happens during the convergence. The eyes are slowly moving inwards. If the eyes are slowly moving inwards, they are creating a beam kind of thing, right? So the angle increases always. Okay, what is the unit of measurement of convergence? Convergence is measured, right? Accommodation is also measured. Convergence is also measured. So what is the unit of measurement of convergence? Okay, so it will be meter angle and prism diameter. So if you look theoretically, meter angle is the thing. At 1 meter, one diameter of accommodation, that is meter angle. And the second thing, prism diameter. So this is the clinical implication. So whenever you are in clinic, we are not using meter angle, right? Have you ever used meter angle anywhere in your clinic? You have done 4 years of optometry and you might have worked in some clinics also. So prism diameter, yeah, that is the thing that we are using in the clinics. Prism diameter, and in theoretical things we are using meter angle. So now we are going towards the numerical kind of thing. Accommodation. How much accommodation is required to focus an object at 2 meter? So the options will be half, 1, 2, 4. Okay, please note down this question because you will need some kind of time. Okay, let me make you clear one thing. The accommodation required at 1 meter, 1 meter of distance, 100 by 100 equal to 1, right? Okay, at 1 meter, one diopter of accommodation is required. So obviously, when you are moving that object to near things like 50 centimeter, it will be 100 by 2 equal to 2 diopter. 100 by 50 equal to 2 diopter, right? When the object is moving closer, then you have to accommodate more. When the object is moving far, you have to accommodate less. If the object is moving to 50 centimeter, the accommodation will be 100 by 50 equal to 2 diopter. When the object is moving far, 200 centimeter, the accommodation required will be 100 by 200 by 100 equal to 100 by 200 equal to 1 by 2, half of that. Okay, so here you don't have to use a lot of formula, and complex kind of things. Just you have to use your common sense here. Okay, this is a kind of common sense question. At 1 meter, you have to understand. At 1 meter, there will be one diameter of accommodation. So at 2 meter, the accommodation will be less, right? Half of the time. Okay. So this is also another common sense kind of question. You don't have to use a lot of logic or a lot of formula to get the answer of this question. How much convergence is required to focus an object at 2 meter? Same thing. So at 2 meter, the accommodation will be less, right? Yeah. If the accommodation is less, the convergence will be less. The meiosis, the constriction of the pupil will also be less because these are the triads of accommodation. So the answer is up because 1 meter angle is created at 1 meter. Okay. So you might be having this question: what is meter angle? At 1 meter, okay, the angle that is created by any object that is situated at 1 meter is known as meter angle. At 1 meter, whatever amount of the convergence is created by accommodation of one diopter, that is known as meter angle. Fine. Okay. So which of the following is not a type of defined convergence? So the question is something different. Which of the following is not a type of well-defined convergence? It means, so there are we have read some of the convergence type of convergence related to the eye. Fine. So which of these is not a type of convergence? Voluntary convergence? Yeah, obviously voluntary convergence. Voluntarily we converge our eyes, right? When we want to see small objects at near, we converge. So that is true. So tonic convergence, that is caused by the muscles. Okay, eye muscles, the tone of the eye muscles in order to make the eye into the state of fixation. Tonic convergence, accommodative convergence. Yeah, obviously accommodation also follows some kind of convergence. That is HY A ratio. Proximal convergence. Yeah, whenever we are moving an object closer, proximal. Yeah, that is also a kind of convergence. Relative convergence. Yeah, this is a relative kind of convergence. This is not a type of the well-defined convergence. Yeah. So where we can use this relative convergence, relative code is that whenever the two eyes are moving relative to each other, either they are converging, they are diverging, okay, that is known as the divergence. So here the answer is relative convergence. Okay. So which of the following method is used to now? So you see basically we are moving towards convergence now. So earlier we were describing about the accommodation. There are some of the numericals with accommodation that we will be telling you after some time in the further slides. Now we are slowly moving towards the convergence thing. Fine. So I don't think I have to explain so much of things about the convergence because you have read a lot of things, right? And I have been told also the same thing that we should not go towards the basic of these descriptions, explanations, and all because everyone is preparing note in their bachelors. They have been studying, students are studying also. So I'll be going towards the MCQs, and if there are some of the points that I need to tell you from the options of the MCQs, then I'll be explaining those things. But detailedly what is accommodation, what is convergence, what are the types of convergence and how they are created, all these kind of things I won't be explaining here. Okay, so please don't mind about that thing because we have to go through the time also. Most of the things will be repeatable, that's why. Okay, so which of the following method is not used to measure HY ratio? HY ratio you know, right? So which of the following method is not used? So heterophoria method, yeah, it's used, right? Gradient method is also used. Estenbaum's method, fixation disparity method, haploscopic method. So, heterometric method, gradient method, fixation disparity method, haploscopic method. These four of the methods are used to measure the HY ratio. Estenbaum's method, that's not used to measure HY ratio. Estenbaum's method is used to measure the ocular motility. So, we'll discuss about Estenbaum's method also in another topic. So, the answer will be C. In clinics, we are using either heterophoria method or gradient method because fixation disparity method and haploscopy method, these things use a lot of instrumentations and it's difficult to record also. So in our clinics, we are using heterophoria method and gradient method. And among these methods also, one of the method is more preferable in our clinic. Which one is more preferable? So we'll be having another okay, which of the following method is used to measure HY ratio that is most reliable in the clinical practice? So the question is, so in our clinical practice, in our daily practice, which is more reliable? Heterophoria method, gradient method, fixation disparity method, haploscopic method. So I told you earlier that fixation disparity method and haploscopic method, these things are slightly difficult in our clinic, and for every patient, it's very difficult because they are time consuming. Heterophoria method and gradient method are easier, and we have been using these two methods. And among these two methods, also gradient method is more preferable. Why? I'll give you one example. From the example, you'll understand. Because in gradient method, there is no role of IPD, interpupillary distance. Okay, I'll give you one example after some time. Okay, what will be the HY ratio for a patient with interpupillary distance 60 mm, exophoria for distance 2 PD, and exophoria at 33 centimeter at present average. So you need some time for this MCQ. Please note it down on your copy. So if possible, you can solve it now. Then I'll show you the answer. Okay. The first thing is, so you might have noted down, right? So the first thing I want to tell you here is, so which method we will use to calculate HY ratio? Obviously, the IPD is given 60 mm. So we have to use heterophoria method, right? And I don't think you don't know the formula to measure the HY ratio, right? Everyone knows over here. The thing is, why I have given this MCQ over here is because you will be having some trouble. Some of the students, yeah, they know how to calculate HY ratio using heterophoria method, but during the sign convention, right? So if you are using exo, when you are writing exo, then you have to write minus in front of the value. When you are having iso, then you have to write plus in front of the value deviation. So when calculating, you will be having very less time. So we get confused. That is very obvious. So the MCQ is also like this. This MCQ is also like that. Exophoria, two prism diameter, exophoria. Okay, exophoria for near is 8 prism diameter, exophoria for distance is 2 prism diameter. So in both the cases, the exophoria is there is exophoria, and we have to write minus for that, right? So minus 8, minus 2, like that. So the C, okay, by convention, minus for exo, plus for iso. Okay, so IPT is 60. We have to write 6. We have to convert it into 6 centimeter. So 60 will be 6. Exo 8 will be minus 8. Minus, we have to minus 2 by 3. 8 minus 2, that will be 2, right? Divided by 3 to 4. So the answer is 4 is to 1. So I want to ask one question over here. So is this HY ratio fine for a patient? Is the HY ratio high? Is the HY ratio low? 4 is to 1. Okay, we'll be having this thing in another MCQ. What is the normal range of HY ratio? 2 is to 1, to 4 is to 1, 3 is to 1, to 5 is to 1, 4 is to 1, to 7 is to 1, 3 is to 1, to 7 is to 1. So what is the normal range of HY ratio? So we are calculating HY ratio, right? Why we are calculating HY ratio? What is the significance of calculating HY ratio? So how much is the accommodative convergence? Is for the accommodation. Whether the accommodation and convergence they are going together simultaneously, smoothly, or there is some kind of disturbance in between the accommodation and the convergence, because we already know that accommodation and convergence should act together for a better binocular vision, right? So if the HE by A ratio is higher or lower, they will be having some kind of disturbance to the patient, some astigmatic symptoms. What is the normal range? So 3 is to 5 is the normal range. B is the answer over here. Okay, this is so in whatever MCQs I have attended till now, whatever kind of exams I have given or I have taken, this question: what is the normal range of HY ratio? Most of the exams, almost 80 to 90% of the exams, they will be asking this question either in MCQ, either in Viva, either in written exam, or anywhere. They will be asking this question. It's the very very important question, and it's very easy to understand also, right? 3 is to 5, you have to understand. 5. So the values above 5. So if the HY ratio is greater than 5, what will happen? The eyes will converge more, right? Okay. Excessive accommodative convergence and accommodative insufficiency under 3. So the more value of the convergence, you have to look here, right? What does 3 by 1 and 5 by 1 stand for? Okay, you have to understand here. Okay, what is 3 by 1? What is 5 by 1? The denominator 1 represents the accommodation. AC by A. A means accommodation, right? So when there is one diopter of accommodation, the eyes converge 3 diopter. Whenever there is one diopter of accommodation, the eyes converge 5 prism diopter, 5 by 1. So if the accommodation is only one diopter and the convergence is greater than 5 prism diopter, obviously there will be more convergence, right? That is the thing. It's very easy. Okay, so this is the example. So this is the example where I'm trying to explain you what is the reason gradient method is more useful than heterophoria method. Okay, so first of all, you read this thing. If a patient has dystrophy of 30% diameter in distance fixation and 36 when fixating at near, okay, the surfacely you read it down. Okay, you don't get deeply into it. I'll explain it in. So this is the important thing. Okay, so yeah, you read it. Fine. Fine. Okay, please stop. Okay, I'll tell you one thing now. In our clinics, so how many of you are practicing the squint, heterophoria, heterotropia in a squint clinic? Most of you, right? So most of you, and for those people who might not have attended a squint clinic, I'll tell you one thing. We are measuring squint. I'm telling squint, okay, for both heterophoria and heterotropia for the easy kind of thing. And now I'm telling squint. We are measuring squint for distance one time, and we are measuring squint for near one time. Fine. And we are seeing the difference. How much is the difference in between the distance and the near prism diameter? Suppose one patient is having 10 prism diameter for near and 15 prism diameter for distance. So the difference is only 5 diameter. In our clinical setting, the difference of 5 is not taken as a major difference. Only if the difference is greater than 10 prism diameter, that is taken into the account. Got it? Most of the patient with intermittent exotropia, they will be having a very high deviation for distance. Okay? And they will be having a very less deviation for near. What is the reason for that? Because whenever a patient is fixating at near object, he will try to exert some kind of accommodation. Whenever he is trying to exert some kind of accommodation, obviously the eyes will converge and the eyes will be straight. So the deviation will be less for intermittent exotropia at near, and the deviation will be more for intermittent exotropia at distance. Got it? So what we have to keep in mind here is, because there will be a lot of MCQs based on this MCQ, this thing, okay? For clinical setting, for any kind of clinical setting, clinical kind of documentation, clinically significant, okay? Clinically significant deviation should be greater than 10 prism diameter for distance and near. The difference should be greater than 10 prism diameter. Then only the patient will be having some kind of problem, uh, okay, problems, aesthetic symptoms or anything. Okay. So main thing is 10 prism diameter, right? Okay. So if a patient has isotropia of 30 prism diameter for distance and 36 when fixating at near, so the difference is only 6, right? 30 and 36. That is not considered to be clinically significant difference. Got it? So the patient is not supposed to have any kind of problems. Got it? And again, the interpupillary distance of the patient is 57 mm. That is less. Okay. If we look at the average interpupillary distance, it will be around 60, 63, like that. Fine. The pupillary distance is 57 mm. So when you are calculating HBI ratio in this case using heterophoria method, the HBI ratio will be 7.7 prism diameter per diameter. Got it? So the 7.7 in the previous MCQ, what we learned, the normal range of HY ratio is 3 to 5. And in this case, although the patient is not having any problem, significant problem, clinically significant problem with the deviation for distance and near, the HY ratio is higher, is 7.7. That is more than 5, right? So the figure is outside normal range, obviously. And by all counts, a high HY ratio. So these kind of considerations must be kept in mind by those who determine the SY ratio by comparing distance and near deviations. This is the reason. So there are a lot of others. Okay, those others, what they said, gradient method because of IPD use cannot be applied most of the time. So they preferred. Sorry. I was wrong. The heterometria method, heterophoria method in most of the clinical settings cannot be amplified. So we have to use gradient method. This is the main reason. So you can see clearly in this example. Okay. So heterometria method is not preferable as compared to gradient method. Gradient method is easier to use also. Okay, I'll tell you how to use gradient method. Most of the students might be knowing how to use gradient method. We have been doing clinical works regularly. Okay, theoretically only. Whenever they are learning about theoretical things, when we are using gradient method, how to use gradient method, we know about the gradient method, but we forget. Okay, time to time because we are not up to point how to use it. We note down this MCQ. What is the HY ratio? In the original deviation for a given distance is 2 prism diameter h of a distance, and with 2 lengths, the amount of deviation is 8 prism diameter ratio. So Which formula you will use in this case? It's very obvious, right? There's no IPD. No IPD is given, so we have to jump towards the gradient method. So you won't be asked any MCQ. Okay, I can't say you won't be asked any MCQ, but very, very, very less chance you will be asked about calculating HUI ratio using other haploscopy method and other methods, right? Only these two kind of methods will be used in used as MCQ. So how to calculate HUI ratio using gradient method? Okay, I'll give you one example. So you have to measure deviation for distance. Okay, you have to measure deviation for near. So every time we are doing a squint workup, we have to measure these two deviations. Okay, so what is the amount of Fourier for distance? What is the amount of Fourier for near? These things we have to measure, right? Then you have to subtract the deviation from near, deviation for distance from deviation for near. Got it? And divide by the amount of the lens that you are putting in front of the eye. So how to calculate gradient method? Suppose there is a patient, okay, he's using his glasses, or he's not using his glasses. Whether he has refractive error, you will use his glasses. If he doesn't have refractive error, you won't be using his refractive error. So the power will be there in front of the eye, and then we have to give some amount of prism in front of the eye. Sorry, we have to give, we have to induce some amount of the prismatic effect in front of the eye. So the lens we are using in front of the eye, you can use one diopter, you can use two diopter, you can use three diopter, five diopter. Okay, you can use up to five diopter of lenses, because you have to excite some amount of the deviation from the eye, right? So in this case, we are using two diopter of lens in front of the patient's eye. So the minus two diopter of lens, okay, obviously they will cause some amount of the deviation. They will change the convergence of the eye, right? So that amount of the change we are measuring using gradient method. With minus two diopter in front of the eye, with minus two, okay, keep in mind, we have to measure distance and we have to measure near. Fine. Subtract near and then subtract distance from near, and then divide by the amount of the lens that you are using, that is 2. Since all the values are in diopter, then it will be very easy for you. So the value will be 5, right? The distance is 8 ISO. Okay, keep in mind here 8 prism diopter ISO. That is the reason we are using plus in front of the 8, and 2 2 prism diopter exo for near. So we are using minus for exo. Okay, by convention for exo there will be minus sign. Okay, the answer is 5:1 in the gradient method. So this is the most useful formula, and in your clinics also you have to use gradient method. It's very easy also. So what I've seen in my clinic, okay, so everyone will be having some amount of experience with their work. In my clinic, whenever I'm using gradient method and I'm using -1 or +1 diopter of lens, then the Fourier will be very, very, very less change. So I prefer using 2, 3, 4, sometimes 4 prism or 4 diopter lens also I'm using. So whenever the amount of deviation is very, very less. Okay. So in theoretically, we have to understand things like this. You can use one diopter of lens also, they are telling. That is the thing. And when you are using how to measure, do you know how to measure the clinical thing I'm telling you? Okay, how to measure Fourier for distance, and you are using this lens. So better to use Maddox rod. Maddox rod. Okay, keep in mind, in order to measure Fourier for distance and near, you have to use Maddox rod, because we have to, because we'll get the patient's response also, and the amount of the deviation will be noticed very nicely in Maddox rod. Clinically, I am using Maddox rod most of the time, okay, to find out the deviation. So, which of the following statement is wrong about the accommodation? Now we're jumping towards the accommodation. Okay, so whenever I'm asking, whenever I am giving any kind of MCQ, okay, don't go only through the options of the options of the questions, because I'm including the whole topic here. Okay, so we'll just look at this question over here. Which of the following statement is wrong about accommodation? So there will be ciliary muscle contracts, general fiber relax. Only 4 things are given over here, right? So there are more than 10 things that happen during accommodation. So you have to keep in mind that what are the 10 things that happen during the accommodation. Yeah, so anything can be asked from MCQ. So this is the thing. that you have to keep in mind. What are the things that happen during accommodation? There are 10 things. I haven't mentioned everything over here. Okay, only some of the things I mentioned. Ciliary muscles contract. Obviously, ciliary muscles will contract. Junior fibers will relax. Okay. Change in radius of curvature of the crystalline lens is more in the posterior surface than anterior surface. Change in radius of curvature of crystallines will be there, right? Yeah, obviously the lens will change, curvature will change, but the lens anterior surface, posterior surface, that is the thing here. So the crystallines are more in the posterior surface. No, no, no. Posterior surface, the change in curvature will be lesser. So the answer is C. Okay, that is wrong. Okay, because the anterior surface, the radius of curvature changes more in the anterior surface. AC depth decreases because of the forward movement. Yeah, obviously. So if the interior surface of the lens is slightly moving forward, if the curvature is changing towards the further interior side, then the chamber will be lesser. Got it? So the AC depth will decrease. That is fine. The answer will be C over here. So you write down, you note down, or you understand what are the things that happen during the accommodation. What are the changes, physiological changes that happen during the accommodation, anatomical changes that happen during the accommodation. Okay, there are some of the theories also that help to understand the physiology of accommodation. So, which of the following is wrong about accommodation? So, this is a kind of numerical, and these numericals take a lot of time. Okay, so I have kept these numericals. Yeah, which of the following is wrong about accommodation? You have to use a lot of brain work here. So, these are the MCQs that will be taking a lot of time in your exam. Okay, I won't say anything. You just read it out. Okay, in order to focus an object at a distance of 25 centimeter, an imetropic eye needs to use 4 diopter of accommodation. At 25 centimeter, 100 divided by 25, that will be 4. That is correct, right? Okay. So 4 diopter, this is fine. In order to focus an object at a distance of 25 centimeter, an eye with 2 diopter. See, the patient is myopic. Okay. He needs to use 3 diopter of accommodation. At 25 centimeter, 4. Okay, the 4 diopter of accommodation is required, but the patient is myopic, minus 2, then he has to use 4 minus 2, 2 diopter of accommodation. So the B is the wrong answer, right? So in order to focus an object at distance of 25 centimeter, an eye with 2 diopter needs 6 diopter of accommodation. So 25 centimeter, the patient will be an immediate patient will need 4 diopter of accommodation that we came to know from the first option. 4 diopter of accommodation is required at 25 centimeter, but the patient is already hyperopic by 2 diopter. So 4 plus 2, that will be 6. That is also correct, right? I have it over here. That A, B, C. Things are written like this. A, B, C, D, E. Okay, these are the options here. The C is also correct. The amplitude of accommodation decreases with age, right? Yeah, everyone knows that. There is a chart. Okay, there is a I think 100 years old graph over there. Everyone knows that amplitude of accommodation decreases with age. That is the reason we are facing breast myopia after the 40 years of age. Okay. For comfortable vision, one third of the accommodation should be kept in reserve. Yeah, this is another MCQ. Fine. For comfortable vision, how much accommodation should be kept in reserve? This is another MCQ. One third of the accommodation should be kept in reserve. You have to keep in mind. Suppose you are having suppose you are having 6 diopter of accommodation, right? Amplitude accommodation, 6 diopter of accommodation. Then you have to keep 2 diopter of accommodation in the reserve, and then use 4 diopter of accommodation. So for a comfortable reading, so you have to understand for a comfortable reading, comfortable. Mainly focus on the comfortable. Okay, the word comfortable. So if you don't want to read comfortable, then 6 diopter is also enough. Fine. But if you want to read comfortable, then 2 diopter is required to take in result. So the answer is D. So fine. Another one. The following are true about an immunotropic patient with amplitude accommodation 6 diopter. So understand, okay, from the question. Most of the things, okay, the answers will be hidden in the questions only. The amplitude of accommodation is 6 prism diopter. So 100 divided by 6, that will be something around 17, that will be 16.67. Okay. So the near point is 33 centimeter. That is wrong because of now we calculated 100 divided by 6 will be 16.6. The near point is 16.67, right? So the first A is wrong. Okay. In order to achieve comfortable reading, you will need to keep it 2 diopter of accommodation in reserve. In the previous MCQ only we discussed if the patient is having amplitude of accommodation 6 prism diopter, 1/3 is required, 2 diopter is required. That is also true. That is true. Okay, first one is wrong, second one is true. If the patient is immunotropic, you will require glasses for comfortable reading at 25 centimeter. At 25 centimeter, yeah, the near point of the patient is 16. Then obviously at 25 centimeter you will be having easy, right? So the patient will not require glasses. Uh, C is wrong. If the patient is myopic, if he is myopic, the near point will come more closer, right? So already the patient is having near point at 16.67 centimeter, and if he is myopic, then obviously the near point will come closer. That then you won't be having any difficulty in reading at 25 centimeter. And the last option here, if the patient is hypermetropic, correct? Yeah, if the hypermetropic patient, the near point will move further and he has to keep some amount of accommodation in reserve also. So he will require glasses for comfortable reading at 20. For hypermetropic patient, it will be difficult. Okay. So in a clinic, yeah. So in every MCQ, I will be going to ask the clinical things because yeah, we are doing theoretical things, we are learning things, and why we are doing these things because ultimately we have to use these things in our clinic also, right? So in our clinic, you might have noticed one thing: whenever a myopic patient is coming, myopic best myopic patient will be coming, so you won't be requiring any glasses per year, right? So you won't be requiring glasses in his early 40s. So most of the myopic patients they come to your clinic for reading glasses only the age after the age of 45 or 50 years. Why? Because for near, although the near point amplitude of accommodation decreases with age, but because of myopia, the near point comes closer. Right? That is the reason they will be easily reading things for near. But hypermetropic patients after the age of 35 they will come to you with glasses. Okay. Is that true? And read glasses. Okay. So at the look at the E option, comfortable. There is comfortable, right? Because you have to keep some amount of the accommodation reserved for comfortable reading. That is the reason he's requiring glasses. -3 myopia. Okay, another myopia, right? It's completely cycloplased. So some of the cycloplastic drug have been used. Completely means atropine might have been used. In order to see an object 25 centimeter in front of his eye, 25 centimeter. Okay, so everything will be in the MCQ. Means 100 divided by 25, 4 diopters of accommodation, right? What power contact lens must you place on his cornea? Got it? So in order to see object clearly at 25 centimeter for a immature patient. Okay, I'm not talking about this patient. Okay, who is having myopia. In order to see clearly at 25 centimeter for immature patient, 100 divided by 25 will be 4 diopter. 4 diopter of accommodation is required. Very easy, right? 4 diopter of accommodation is required for immature patient. Then for a -3 diopter of myo plus 4 is required, but he is already having -3 by God's grace. 4 minus 3, that will be plus 1. Very easy, right? You don't have to use so much of formula over here. Just a simple logic. Simple logic, the answer is 1. Right? What accommodation required for non-cycloplegic person? 4 months. There is no role of accommodation over here. Okay. So in the coming days, when you'll be having other topics, we'll be discussing about some of the MCQs, some of the topics, because BSV you can be having only one topic, right? You won't be having only one topic for binocular single vision. So suppose today I'm talking about accommodation and convergence. So I leave convergence and accommodation for today only. I won't be discussing anything about BSV and BSV and this uh, pupil and accommodation in other days. Okay, we can't say like that because almost all of the things are related with each other. Okay, whenever you are learning anything about physiology, pathophysiology, asthenotic symptoms, we have to talk about accommodation. We have to talk about convenience because these are the things they will be useful every time. The question of the day is, so this is not related to the MCQ, right? So just a small curiosity for you. Constriction of the pupil is faster than dilation, right? Okay. What is the reason? What is the reason constriction of the pupil is faster than dilation? When you are using a torch light and you put that torch light in front of the eye, look at the pupil, constriction will be very fast. Fine. Yeah, and when you are removing the light, the dilation will be there, right? But the dilation will be slightly slower. The time taken to constrict is very fast as compared to the time taken to dilate. What is the reason? So this was one of the question that my mentor asked me even after completing my internship. So after the internship, when he asked me this question, I was really okay. I didn't know the answer of the question because it never came into my mind. What is the reason? Yeah, obviously we see that constriction is faster, dilation is slower, slightly slower. What is the reason? Because we never studied so. Therefore, near vision complex we have been studying from our bachelor's level. We see the diagrams, we understand things, we write those things in our exam, we pass our exams also with very good marks. And some of the basic things, okay, some of the things that are in depth, okay, we forgot to mention those things. That is the answer. I'll give you the answer. Okay, I won't give you without giving you the answer. That's fine. So the constriction you have to understand, dilation you have to understand. Constriction is caused by the parasympathetic pathway. Dilation is caused by the sympathetic pathway. Right? Look at the pathway over here. Constriction, the nerve impulses will go to the ciliary ganglion, heading the westphal nucleus out of the third nerve. Okay, that is the constriction. For dilation, superior cervical ganglion and then spinal cord. Okay, keep this thing in mind. Spinal cord and Edinger westphal nucleus of the third nerve. Edinger westphal nucleus of the third nerve, that is in your brain, right? The upper portion of the brain. Okay, the eyes are on the front side. Exactly on the back side, you will be having Edinger westphal nucleus of the third nerve. But sympathetic pathway, the final position is spinal cord. The spinal cord is spinal cord is slightly below the neck, right? Towards the neck portion. So the distance, look at the distance. Now we move towards the right side. Look at the right side picture. You will be seeing A and B written over here. A and B. A represents constrictor, B represents dilator of the pupil. The A is in red line, B is in black line over there, right? So look at the pathway by the A. It's very small. Okay, it's smaller. From A, okay, it's smaller. Look at the B. It's going hugely downside. So look at the pathway. The pathway is larger, right? It's greater in the B, A, it is shorter. So shorter pathway, shorter time will be taken. Greater pathway, greater time will be taken. Okay, fine. So hope you understand this. So that is the reason constriction of the pupil is faster than dilation. Fine. So the development of accommodation. So yeah, any of the things can be asked in MCQ. Okay, now the MCQs are done. Only the things we have to keep in mind is okay, you can note these things. Okay, these things. Okay, I haven't taken these things from PPT or net uh, browsing and all. Okay, I haven't taken these things like that. I have taken these things from the renowned books. So that is the reason I haven't given any references over here. So these are from the books. These are not from any media, some websites. Okay. So the depth of focus greater at 1 month. Why depth of focus is greater than 1 month? Because the eyes are smaller and the pupils are also smaller. So if the pupil are smaller, depth of focus is also smaller. Yeah, this is another MCQ. Okay, what happens? The pupillary changes and depth of field, depth of focus changes. Okay, you note it down. What happens when the pupil are smaller? The depth of focus increases, depth of focus decreases. This kind of MCQs will be asked. Fine. Yeah, what's the relation in between depth of focus and size of the pupil? This is another MCQ. Depth of focus decreases with improvement in accommodation. Yeah. So the each point each point will be having one MCQ. Okay. The main thing is you have to understand the main thing, and then you have to calculate accordingly. Yeah. So because we have on the yeah because we have read in our books accommodation starts at 3 months of age. Okay, in some of the books we have read accommodation uh, starts at 4 months of age. Accommodation will be there at 1 month of age also, but that is up to 19 centimeters. 19 centimeters. So the proper accommodation. So whenever you are having any MCQ, you will be asked about the proper accommodation. Okay, at what age the accommodation develops, then the MCQ, the options will be either 3 or 4. Okay, 3 and 4 they won't be asked at the same time because some of the MCQs 3, some of the MCQs 4. That is fine. Okay, if you have 3 options, then you have to tick on the 3. You have 3 4 months, then you have to tick on the 4. At 4 months, the proper accommodation at 10 centimeter will be offered. Okay. So in our clinics, yeah, the second thing is in our clinics, what is the normal point of NPC? Okay, what is the normal point of NPC? The patient will be, the questions will be like this. Normal point of MCQ, that is also 10 centimeter. Okay, keep in mind 10 centimeter. That is the reason I have taken this point 4 months 10 centimeter. Got it? Near point of convergence 10 centimeter is enough. Fine. Development of binocular vision. Anyway, we have to discuss binocular vision in another coming days. But you can write development of binocular vision. After 2 months, the child will be doing the monocular fixation. There are 3 points of binocular single vision. 3. Okay, you know that. You have to understand what is binocular vision, what is biocular vision, what is monocular vision, monocular, biocular vision, binocular vision. The 3 things you have to keep in mind. Because whenever you are treating a patient with amblyopia or whenever you are treating a patient with binocular single vision disorders, the 3 things should be done. Okay, binocular, biocular, and monocular, biocular, and binocular. The 3 things come into step by step things. These things are very, very, very essential for a binocular vision. Okay, I'll be providing you this PPT also in the coming days. Yeah, fine. So we're done for today. Some of the other MCQs I'll be sending you in the coming days also. I'll forward it to Kapil.
Okay, sir. Once again, thank you so much for such a wonderful class. And let me check out the question if anybody raise on the comment section. So I would like to request all the attendees kindly comment on the chat section, and Krishna sir will be happy to answer your question. So if you have any question or if you have any doubts regarding the previous discussed question, you can also comment on that. Okay, we are waiting a few minutes more here, and then after we are having our next session on ocular anatomy and physiology, which compile all the anatomy and physiology within the 2 hours. So it will be a rapid class. So don't miss that. Okay, I guess we answered the all most of the question. So we also make one WhatsApp group. So you might be over there, and Krishna sir also over there. So if you have any doubts, kindly comment on there. If you need any notes or anything, kindly comment on the WhatsApp group, and Krishna sir and our team will be help you to
Yeah,
get.
I'd be very, very,
Yeah.
very happy, okay, if you're sending some questions, some of the doubts, anything like that, because I'm continuously learning. I will be learning. You will be learning. Everyone will be learning, and everyone will be getting some points to understand better about the optometry. So, if there are any doubts, please share. I will try to learn some of the things. I will try to learn from myself. I will try to learn from you. I will try to learn from books. Okay, because learning never ends. You don't have to feel inferior whenever you are preparing for any exams. Yeah, go. You have to study. You give your best. Okay, you don't have to take any tension because you saw the MCQs, right? These are not the top MCQs. These are very, very basic MCQs. The questions will be like this. Okay, for any master's exam, you won't be asked hard questions. Okay, only the basic things will be asked. So I'll be available every time. If you have any doubts or anything, please text me. You can text me also. You can text Kapil also. He's doing a very, very good work here. He's helping so many students. Okay, I'm very proud of him. Very, very good initiation he has started. So that's very good. Okay, it's very.
So once again, thank you so much, sir. Sir, can we in the today's session, and then after we are having the next session on introduction to the binocular vision, is space perception and physiology of ocular movement, right, sir?
Yeah.
Yes.
So
After the
at the
today.
end of the our presentations, okay, at last also when you are finished with these topics, okay, I have some 5 topics in binocular single vision. So after that, I will give you some of the MCQs that are for the geometrical optics, that are for refraction, uh, geometrical things, optics. Okay, these kind of things. Okay, the simple things that we have learned in first semester, second semester, third semester. These MCQs will also I'll be providing you in the coming days. Okay, so although the binocular single vision, okay, you will be asked very less questions. I think 10 to 15 questions will be asked from these things. Apart from these things, whatever I have, the MCQs I will be providing you in the coming days. Okay, don't worry about that thing. So whatever I have, I'll give you. Fine.
Okay, that will be great. So here with I announced that today this closed of the session, and we will meet after the around 45 minutes at 8, 8 a.m. or 8:10 a.m. So once again, thank you so much, and
Thank
thank
you
you
so
so
much,
much,
Kapil.
Krishna sir. Have a good time, sir. Thank you.